Testing, testing. Testing, 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 testing.
Yes. Go home and do that. That's a great idea. Give me just a minute to get this set up. It's a great idea. It's a disaster out there, isn't it? It's really.
I'm here because and so
that's good. Just let me focus on getting this done. We're going to start here momentarily. That sounds good to me. You know, that's probably pretty easy. You get there. There's a go-to meeting announcement.
yeah, I saw that.
Set up with the microphone here.
Okay.
So it's already on, but it's on mute.
Okay.
And you can see that switch right there. That's how you know it's on mute. Then it's live.
Okay.
So I'm going to keep it on mute. And then when you're ready to talk, you can just
I'll just put it in my pocket, right?
So yeah, you throw it in your pocket, and then you can clip the microphone itself to your left lapel.
Okay. That's fine. I'll just put it right here.
Sure.
Because Chet's going to talk first.
Right, and this is for him, actually. So you can get hooked
Okay.
up,
Oh, okay.
and he can just do this one.
He's going to put some slides into my computer.
Perfect. So this microphone is for you, sir, when you are ready. It'll be sitting right here. You can leave it up here when you're done. No problem. Well, it's on right now. When you're done talking, just press this little red button at the bottom and hold it down for about 3 seconds. And Dr. Shapiro, just so you know, only what is said into the microphone gets recorded. So if someone asks a question at the end, you want to make sure to repeat the question into the
Sure.
Perfect.
Not a problem.
Well, then we are all set up. If you want, I can save you a sandwich instead of a
I
salad.
had a half.
Perfect.
Just gonna jump right in here. It's just some pictures of Bob, you know.
Right here.
This guy.
Yeah.
Okay.
Okay, so let's escape here.
That might be, that's right there.
Yeah, it is.
Probably the top one says Gorlin something. Yeah, just, you can either run it right from your
Right,
your
this one?
desktop. Yeah.
Okay, well, just run it right from here. We can do that, can't we? Sure.
It
There
just
you
runs
go.
automatically.
Yeah, right.
Okay. I'm just gonna step out for a second. Is this broadcast?
It's not broadcast because we record it.
YouTube.
Yeah. We're getting famous.
So this is going to be on YouTube?
Yes, it's what we used to record it. But, yeah, it's a cool way for our yeah, it is. And you know, our purpose is really to do something. So everyone can make it.
I always think that there's possibility, because I've never heard of
Yes, yeah, it's a good way for new girls.
Well, welcome everyone to Pediatric Grand Rounds here at the University of Minnesota's Amplatz Children's Hospital this snowy December 6, 2013. This is a special Grand Rounds for us because it's the 6th annual Robert J. Gorlin Lecture. And as many of you know, Bob was a colleague of ours, a trusted member, a geneticist for several departments. Although he was formerly trained in oral pathology, he learned and actually promulgated the concept of defining genetic diseases under the rubric of syndromes, putting together different aspects of a disease to come up with a common etiology and define a clinical condition. And many of us relied upon him daily for this kind of expertise. During his career here, he was Regents Professor at the University of Minnesota, a very distinguished title, and published hundreds and literally hundreds of articles defining dozens and dozens of clinical genetic syndromes. In fact, back then, the university had a rule that everyone after age 65 had to retire. And remarkably, he got additional funding from outside, stayed on, and published even more publications after he retired than before he retired. So I think Bob would be very happy today to hear the talk by our invited speaker, the Robert J. Gorlin lecturer. This year will be Dr. Elsa Shapiro, another one of our colleagues. Elsa began her career doing a PhD in psychology here at the University of Minnesota with a minor in psychiatry, and then she did a fellowship at Washington National Children's Hospital in Washington, D.C. She returned to Minnesota, and many of us know her as interim division chair and head of the neurology or neuropsychological division, which has kind of changed names from time to time, but she's always been one of the most brilliant and expert leaders in the field. In fact, I became familiar with Elsa right around 1983 when we started doing bone marrow transplants for Hurler's syndrome. At that time, it was the first bone marrow transplant in the U.S. for Hurler's syndrome, and we understood and defined the concept of metabolic correction. But the most important part of the disease was really the brain and mental retardation and preventing those problems. And Elsa Shapiro became involved and worked with Bill Crivet to put 2 articles in New England Journal as well as many other publications defining what worked and what did not work for hematopoietic stem cells transplantation, and also funded the first network grant across the U.S. to look at bone marrow transplant outcomes for these inborn errors of metabolism. Elsa herself has many publications. She focuses primarily, I think, on lysosomal diseases right now, and we're grateful to have her as a co-PI of the NIH-funded Lysosomal Disease Network. She also has interests in lead and even cerebral malaria. So, Elsa, thank you very much for gracing us with your expertise today, and I'll turn the podium over to you.
Can you hear me? Let's see, is this on? Is this on? Yeah. Maybe not up high enough. Okay. I just wanted to start. Is that microphone on? See? Yeah, okay. I just wanted to start by saying something about Bob Gorlin. He was a friend and really was interested in various syndromes and always interested in the kinds of comments that I would have to make about various, particularly MPS kids, kids with mucopolysaccharidosis, which I'll talk a lot about today. But I think he would be amazed in the years since he died the progress that has been made in the field of genetic disease and the kinds of changes that have occurred in the field in order, to really help the children with these inborn errors of metabolism. I think he would be thrilled with the changes, and we all appreciate his contributions to the field. Like disclosures. I'm going to start by talking a little bit about the roadmap for this presentation. I'm going to begin with a discussion of dementia, particularly how childhood dementia differs from adult dementia. I'm going to talk very briefly about MPS 1 and 3 because those are the areas that I've been doing, most of our group has been doing a lot of research in. I'm going to talk then most extensively about neurocognitive assessment in MPS 1 and 3, some examples and some challenges. I will briefly talk about neuroimaging and then how one can integrate neuroimaging with neuropsychological testing and then conclude with discussion of how this approach can be used in other diseases. So, as I just said, new treatments for diseases that affect the brain are on the horizon, and we've had many new treatments, and they require sensitive measures of disease progression and treatment outcome in order to determine whether any intervention might be beneficial. So the goals of our research program are to define disease-specific trajectories of brain behavior associations in genetic diseases. And we do it for two reasons. First, to look at the natural history of the disease, to track disease progression, and also to monitor change with treatment. So we have some sort of basic premises that we work off of. And the first one is that genetic diseases that affect the brain have altered neurochemical, neurophysiological, neurodevelopmental processes that result in disease-specific phenotypes. I think that this is something that is somewhat novel, but I think that we have demonstrated that there are very specific kinds of patterns of neurocognitive and behavioral abnormalities that are associated with specific diseases. And we've based that on both clinical and research data. So one of the things is, though, that because we're working with very, very young children and children who are very impaired, our measurement of neurocognitive growth and decline in both structure and function require alterations in the way that we collect this data. We just don't go in and give an IQ test and that's it. There are alterations that are necessary to get very precise data that is particularly true in children of very young age and children with very impaired functioning. So I'm going to be talking about examples from two studies. One is the study that comes out of the Lysosomal Disease Network on the mucopolysaccharidoses, and then a study sponsored by a pharmaceutical company that was a natural history study of Sanfilippo's syndrome type 3. And both of these studies have the goal of understanding the cognitive progression, the brain imaging, and it changes over a period of time. So, going into the first topic about dementia, neurocognitive decline is very different in children and adults. One, in adults, you have maybe a not so static, but mostly static organism, that there is decline from a known level when you have dementia. You can determine that if you don't have a previous IQ test from levels of education, occupational attainment, and previous functioning. So you have a sort of benchmark of where that patient has been. In children, the decline is much more difficult to detect. They may continue to show some growth in cognitive function, but at a slower rate than their peers. We have no knowledge of what their premorbid level of functioning is. And, you know, the real issue here is that the child's development is sort of a moving target, and you have to be able to determine how this child is differing from the growth and development of a normal control group. So we define dementia in children as an alteration in the normal course of development of mental functions due to neurologic disease. It is a rate of change. It is not the same as mental retardation. In mental retardation, you have a slow progression of cognitive functions, but in dementia, you have, you assume that the child began life with a more normal, maybe a slightly subnormal, but a more normal rate of cognitive development. And this alteration in development in children who have dementia is defined by three possibilities. One possibility is the slowing of normal development. The second is just a plateauing, no development, no loss, just staying at the same level. We don't expect children to do that. We expect them to gain milestones. And then finally, when the disease process kicks in, there is a loss of mental function. So use of things like IQ, as I mentioned before, or even the developmental quotient, doesn't tell the whole story. So let's see if I can figure this out. Okay, got it. Okay. So this is a theoretical chart that shows here the vector of normal development in a child, where their chronological age and their developmental status are progressing at approximately expectable level. Here is the downward vector of disease effect. And so what you often get in children who have these inborn errors in metabolism is at the beginning a normal developmental progression, some slowing, and then plateauing, and then a decline. And this is the resultant of these two vectors. So I think this is sort of the model that we always use to discuss what happens in childhood dementia. Okay. So I want to move on now to mucopolysaccharidosis. Many of you are familiar with it. This is a disease that everybody here at the University of Minnesota is pretty aware of because of the pioneering work in bone marrow transplant and in treatment of genetic diseases. And we see a whole bunch of these kids, more than any other place in the United States. And it's an autosomal recessive rare disease with the deficiency of the enzyme alpha-L-iduronidase, which fails to degrade what are called GAGs, and then they accumulate in cells and organ systems. And so you've got a multi-system disease. This little cartoon shows you the real diversity of problems that these children have. We're going to focus on cognitive decline and abnormality, but suffice it to say that all of these affect this, and so we can't look at cognitive decline in isolation. So this is what these children look like. This is the mildest form of the disease to the most severe. These children are transplanted. Hematopoietic cell transplantation prevents cognitive decline. And this is a sort of moderate Hurler-Shea syndrome, usually treated with enzyme replacement, and then a milder form diagnosed in adolescence also treated with enzyme replacement. Note that the physical symptoms cut across all three. The differentiator is primarily the cognitive decline that is seen in this form, and some here, and very little here. So I'm just going to move over to MPS III, which is the other disease entity that I'm going to talk about. Actually, MPS III, Sanfilippo syndrome, was named here by Cy Sanfilippo, who was a pediatrician here at the University of Minnesota. This is a real neurodegenerative disease where primarily the problems are neurological. There are very fewer somatic features, and that results in a delay in diagnosis. Many of these individuals, because they have no physical symptomatology and it's only cognitive, nobody really understands what's going on with them until they start to lose milestones. They slow in language and cognitive, and that continues till death in the second decade. And the behavioral abnormalities are unique in this disease. They're significant, and they differentiate MPS III from all of the other diseases. Children diagnosed very early, before age 6, usually have a classic rapid form, and those diagnosed over 6 have a slower course, but the decline is no less profound, and the result is no less profound for them. And there are no evidence-based treatments at this point. Okay. So those are the two diseases I'm going to use as examples. And so I'm now going to turn to neurocognitive development in young children and how we can measure them. So there are basically three methods of measuring cognitive development. We can use standardized scores that are based on normative data gathered by researchers and test developers and big corporations who sell neurocognitive tests to us psychologists. Example, IQ. What you get is a standard score that reflects how many standard deviations from the mean, the normal population mean, the child is. The problem with this is that all of these tests are geared for sort of the general population, and there's a floor. None of these tests will go below an IQ of 55, which is 3 standard deviations below the mean. And so you have no sensitive way of measuring below that level. The second way of looking at these scores is, or cognitive development, is age equivalent scores. So they're also based on normative data, but here we can look at a rate of gain, this plateauing or loss of skills, and we can compare what that looks like to the normal population. So that's a little different way of looking at, it's sort of like, for you pediatricians, looking at a growth chart and actually tracking what the individual number is in terms of height, weight, head circumference, and so forth. So this is not something that psychologists have been very familiar with, but are now becoming more familiar with in the last few years. So, and then the final way we can look at these cognitive difficulties in young children is by getting a developmental quotient, that is taking the age equivalent score and dividing by the chronological age. And we get something, it's not an IQ, but it's some sort of ratio that represents how this child is performing relative to their peer group. I would just refer you to a paper that is just being published by one of our group, by Kate Delaney, that outlines all of these different kinds of approaches. Okay, so I have now some examples from MPS 1 and MPS 3, and I just want to run you through these examples of how we can look at and what the problems are in these different ways of gathering data. So this is an old graph that was given, this was before we ever started transplanting these children. And what you see is age and mental development. That's like an IQ in untreated children or prior to treatment in 137 children. And notice you have this sort of floor here. There's nothing below 55, 50 in this case. And that's because the test doesn't go any lower. And so we don't really know what happens down here. We don't know whether some of these kids are way down here and this line might be even more steep than this. But this is what we can get using an old method of using what is equivalent to an IQ. Okay, now I'm turning to MPS 3. We just completed this natural history study of MPS 3. And one of the very interesting things, we looked at these kids, their developmental growth curves over 1 year for patients who were in the more severe group diagnosed under age 6. And what we see here is that there is a curve here where kids are early on continuing to develop, and then they go downhill, and then they level off. And so this is sort of a repeat of that theoretical curve that I mentioned before. This patient, actually, we do have a third point, and there was a precipitous drop down to about here. So he's sort of an outlier, but all of these kids end up really pretty severely impaired. So what's really interesting is going back to our historical controls and plotting out the age equivalent scores for our patients with Hurler syndrome. And you know, it looks not so different than this, the same sort of curve. And one of the very interesting things is, and we don't understand this yet, and we need to find out about it, is 28 months seems to be the ceiling of development for this group as well as for this group. And so we're very interested in why that might be a ceiling for the development of children with these inborn errors of metabolism. So then, when transplant came along, we were able to look at something I can do with this. Yeah, maybe it's too close. How about that? Is that better? Okay. So when transplant came along, we took this sort of developmental growth curve approach and looked at children who were transplanted and looked at what their slopes of development were after transplant. You remember this went down like this? Well, these kids are developing, albeit at a slower rate than normal. And these are children who were transplanted before the age of 18 months. And here are patients transplanted over 24 months. And you can see here the great variability here, but mainly most of them under, this is the 2 standard deviation line, most of them below that. So the first thing we learned was the earlier the treatment, the better the outcomes. And that is a general kind of rule for most of these inborn errors of metabolism that cause genetic abnormality, that are caused by genetic abnormality. Okay, so now, you remember I told you that you have three kinds of data. You have IQ-type data, you have age-equivalent type data, but here we have the age equivalent divided by the chronological age of the child. And when you do that, what you see is this. And this is really dramatic. I mean, we were just amazed to see how the decline in these children occurred. These are the children in black who are diagnosed early, and these are patients who are diagnosed later and have a slower decline. This patient here was misdiagnosed with autism for many years before he was diagnosed with Sanfilippo syndrome. He really belongs in this group, but he was diagnosed after the age of 6. So this is what you get when you look at this in a age-corrected sort of manner. Okay, so that's younger kids. What do we do with the older kids? How does our approach to neurocognitive assessment differ? So we can use IQ scores in older kids and Z-scores. Sometimes we use the raw scores or age-equivalent scores, but mostly we use standardized scores. The problems that we have, particularly in our MPS I patients, is all the confounds that there are in understanding what is their actual cognitive level, because they have hearing loss and they have visual problems, they have pain, they have poor motivation due to pain and other factors, lack of motor competence because they all have carpal tunnel syndrome. And then there are practice effects. We don't get too bent out of shape about practice effects because we like to see them actually in our patients rather than not, but we do try to compensate for them. And so we measure IQ, we measure daily living skills in these patients, memory, attention, spatial ability, speed of processing, and then behavior and emotion, which has turned out to be a bigger factor than we had imagined before we started these projects. So if you look up here, you can see some of the ways that we graph this data. So this is the normal average IQ of 100. These are a group of different kinds of mucopolysaccharidoses. Okay, so our attenuated group is the green ones up here. Our older transplanted kids are here. Our younger ones are here. Oh, I'm sorry, it's the other way around. Younger ones and older ones. And these are two kinds of mucopolysaccharidoses, type 2 and type 6, which have normal IQs. So what we're learning here is that with the younger kids, they do better at first. And then as they're older, perhaps they're not so good. But you know, the older ones were transplanted before the kids who are here. They may not have had co-occurring enzyme. They might have had less sophisticated transplant approaches. So we don't know whether this difference here in age is due to transplant or just a decrease in functioning over age, over time. And the other thing, this is just an aside, I haven't talked about adaptive functioning, but we were just amazed to see that our attenuated patients had poorer adaptive functioning than our transplanted ones. And I think this really has something to do with parental expectations. Kids who are transplanted, the expectations are that they're not going to live, and so anything is good from the standpoint of parents, and they help their kids to achieve better. The attenuated patients, the parents are expecting more, and the kids are getting discouraged, I think. Anyway, and one of the things in our project that we've just got accepted for publication with Dr. Ahmed is to find a specific mutation that seems to lie between the Hurler patients and the Hurler-Shea patients, a specific mutation that impacts cognitive functioning. We were amazed to see the degree to which this L238Q, compared to those without it, were much lower functioning on the left than those on the right. So those are some of the things that we're looking at. And then another area of focus for us is attention span, and we're particularly interested in that because it seems to be associated with disease of the white matter of the brain. And I'll show you some data later about this, but in this case, we see that all of our patients, including MPS II and MPS VI, and all forms of MPS I, have very poor attention span and often have difficulty in focusing and responding appropriately. Okay, so I'm going to move on to brain imaging methods. And then we'll come back to the neuropsych piece. And I'm just briefly going to talk about MRI analysis in these patients. So in MPS I, we have very abnormal looking brains. We have lots of inclusions around the perivascular area, in the perivascular areas. We have big ventricles, white matter, increased signal, and usually some atrophy. In MPS III, we have atrophy, but you know, their MRIs don't look so bad when they're young. And so we don't see any of the other characteristics like these. Now, clinical scans have not been very effective in tracking disease, or we can identify the patients. We can say, oh, this looks like an MPS I patient by looking at a clinical scan, but it doesn't tell, the clinical assessment doesn't tell us anything about disease progression. We're trying to, one of our, Dr. Nestrasil in our group is developing a new clinical system which we hope will be more sensitive to disease progression, which is more quantitative. But this is what they look like. These brains are not normal looking. This is a 14-year-old boy who had an early transplant. As you can see, big ventricles and poor differentiation of white and gray. And here we see an adult woman with the mildest form. Lots of these little holes, Swiss cheese type brains. These little Verco-Robin spaces, they're called, the perivascular spaces, do not correlate with cognitive function at all. She has normal cognitive function. This person has low average cognitive function. And here's a 16-year-old girl with Hurler-Shea. She's actually one of these L238Q patients, the ones with the more severe form. And she has many, many impairments in her cognitive function. And so, you know, you can't tell by looking at these brains which are the more severe, which are the mildest. In MPS III, which is the other disease we talked about, the neurologic disease, this brain looks pretty good. This is, you know, he's got a very low developmental quotient, but we don't see a tremendous amount of atrophy here, because atrophy is the main thing that we see. But look at this 8-year-old girl, where gray matter makes up only 30% of her brain, here 70%. And she is functioning basically like a 1-year-old in terms of her developmental level. So you can see all the spaces between the sulci here, gyri, that marks it as atrophy. So, but these clinical methods are not very good. And so what do we do to quantify them? So there are a lot of different methods out there that we can use to quantify decline. There's volumetric analysis, where we use specific sequences and we can segment the brain either automatically or manually and get volumes for any part of the brain that we want to calculate. However, these are programs, software programs, that are based on more normal-looking brains, and some are inaccurately segmented and need manual adjustments if they have very abnormal brains, or the brains are very young because white matter and gray matter has not yet differentiated. So it's very difficult in some cases to get good volumetrics. I'm going to also mention that we do manual tracing. We do it for areas that are hard to read, such as the hippocampus and the amygdala in the brain, areas of memory and emotion. There are lots of other methods that we have. Diffusion tensor imaging, which looks at functional connectivity, the white matter fiber structure, and here tractography, using the data to model neural tracts. We're looking now at resting state fMRI, which is a way also of looking at functional connectivity. And then we are looking also at metabolic changes, where we can look at the neurochemistry in the brain and get relative concentration of brain metabolites. So these are different methods of quantifying the neurological state of the individual. So these automated volumes, this is a picture of how, I don't know if you can see it, but there are lines here. The program automatically segments gray from white and different regions of the brain. And as I said before, in highly abnormal appearing brains and in children under 3, we have a very difficult time, and we have to manually adjust each one of these so that we're getting accurate reads. So we have to carefully control the MRI sequences that we use and inspect each patient's MRI for whether the segmentation is done correctly. It's very time-consuming. Okay, so what can we get out of it? Okay, so you remember I showed you those pictures of the decrease in MPS 3 cognitive performance. Here is the gray matter volumes. The neurons in the brain make up the gray matter, and this is what this looks like when you carefully segment the brain and look at the decrease over time, over 1 year, by age. So this is what we get when we are doing manual tracing. We get these, we can get images of the hippocampus and the caudate. We have some new methods also of doing shape analysis with these, so that we can see if the abnormality may be due to shape problems. One of the things that we are particularly interested in MPS 3 is the amygdala. You remember I said there are lots of behavior problems in those patients, and the reason for those behavior problems turns out to be probably related to this amygdala is deep in the brain, and it seems to decrease in volume by 12% in 1 year compared to the adjacent hippocampus, which is 4%, and the gray matter, which is probably closer to 30%. So you can see that we have some interesting sort of specific results in MPS III. And we have correlated it with behavioral measures such as loss of fear and measures of autism and found very strong relationships. Now, this is an old study that I did. Remember, I mentioned fractional anisotropy, where we were looking at the connectivity of the brain. This is a comparison of attenuated with severe, and these are box plots that represent the fractional anisotropy. That is a measure of the connectivity related to the corpus callosum, the connection between the two hemispheres. And we see that our MPS severe, our Hurler patients, have a much lower degree of connectivity than in our attenuated patients. And this is something else we can do, and that is fiber tracking. And fiber tracking basically takes those diffusion tensor values and tracks various fibers extending from a region of interest, which here is the corpus callosum. And you can see here's a patient with Hurler-Scheie syndrome compared to a control, and you see a very disorganized, not very clearly demarcated fiber tracks that lead from the corpus callosum to the cortical gray matter. So I think I'm going to skip this. These are just some results that we had, and move on to the final topic, and that is what the neural basis is of cognitive abnormality. So what have we learned about brain behavior relationships from these in MPS I and MPS III? So in MPS I, we have found that poor attention and compromised white matter using both volumetrics and diffusion tensor imaging, both of these methods, has focused our future research on trying to figure out why that is. Is it the effect of disease severity, or is it the effect of the transplant itself? And transplant is known to have a negative effect on the white matter of the brain. So we have a situation where things are confounded, the treatment and the disease. So this is one of the things that we have in our future plans, is to look more carefully at attention and compromised white matter together. In MPS III, the analysis of developmental quotients and the loss of gray matter yields a dramatic association of the two, and I'm going to show you some of that in a minute. And we feel confident in using cognitive outcomes in future treatment trials as a result of this sort of confluence of both cognitive testing and imaging. And then, as I just mentioned, we have been able to identify that the amygdala is likely associated with unusual and very problematic behavior problems in MPS III. So these are some graphs that we have looking at attention and corpus callosum volumes. So here are normals. Here are our attenuated patients. They're very low. And here are our Hurler patients with this very different sort of relationship between attention and corpus callosum volume. These are two different, let's see. Yes, so this is the anterior corpus callosum, posterior corpus callosum. And this is the central corpus callosum and the total corpus callosum. If we just look here at the total, basically you've got the same thing in all parts of the corpus callosum. But what you are seeing is that these patients have a smaller corpus callosum. This is the and poor errors of omission, because they're over on this side, and their errors of omission are down here compared to the normal controls. The Hurler patients have a very different relationship. We need to find out more about what that's all about. And again, here we can look at that fractional anisotropy seen in the diffusion tensor imaging and look at these very nice correlations with attention. So I think that's an important thing that needs further research. Going back to MPS III, here we have the relationship between DQ and decline in gray matter over 1 year. This is a very, very tight relationship with great significance, and it tells us that we can use DQ as a measure of treatment outcome when these treatments, which are right on the horizon, are present. So these are the lessons that we've learned. One is that cognitive assessment is sensitive to change over time and does reflect phenotypic differences. In diseases such as MPS III, cognitive decline may be the primary measure of outcome for any new treatment. But it's really important to choose the right measures, those that answer the important questions in the field, and those that are appropriate to the age and the disease of the patient. And I think that this is, one size does not fit all when it comes to either disease or age. And I think this is the real take-home message here. Imaging turns out to be a very important biological marker and can shed light on the neural basis of these functional changes. However, it's even more sensitive to inter-examiner, inter-center kinds of differences. And we need to have exact protocols, and they need to be adhered to, and the proper analysis methods employed. So I've talked a lot about MPS I and MPS III, but this sort of approach can be used in any disease that you're interested in. And whether it's a lysosomal disease or it's another disease, such techniques have been successfully applied. We've used this kind of approach with adrenal leukodystrophy, with metachromatic leukodystrophy, with the gangliosidosis. Chet has worked a lot on that, looking at the relationship between cognition and imaging. I think that mucolipidosis is another disease in the future. I think it can be used in Fabry, Gaucher, and other lysosomal diseases. But other genetic diseases like Williams syndrome or fetal alcohol syndrome or muscular dystrophies which have cognitive impairment, infectious diseases. I see Chandy and I have worked a little bit on cerebral malaria, and using this sort of approach, you can really get the same, pretty dramatic outcomes. So childhood cancers and their treatment also lend themselves to this approach. And I think these strategies have been employed to examine brain-behavior relationship in all of these conditions. So what are the future directions? One, better treatment options for MPS 1H to prevent the residual cognitive impairments, particularly in white matter that we're seeing. This is an area that really needs work. And better and earlier treatment options for our attenuated patients, because they have cognitive problems as well. And new treatment options for our MPS III patients. intrathecal enzyme, gene therapies. And I think the data that we have generated here at Minnesota in the natural history study will provide a comparison of the developmental trajectories of these treated patients of future treated patients to our natural history data. And also to direct some treatment toward the behavioral abnormalities which we have found. And that's about it. I want to thank all the patients and families who have been in our 2 longitudinal studies, and our group, Igor Nestrasil, Victor Kovac, and Aliyah Ahmed for their innovative work in imaging, Kate Delaney and Brianna Young for their innovative work in neurodevelopmental assessment. And our study sponsors and the CNBD and the CMRR, both of whom have provided us a lot of support. Thank you. Happy to take any questions.
Elsa, one thing you didn't mention, I think, is your discovery, you and Mike Potegal, of the relationship of the Clover-Bucy syndrome and Sanfilippo syndrome.
This was too much.
And you're seeing so much of a relationship between the brain disease in MPS 1 and 2 and 3, when historically we've always differentiated 1 and 2 from 3, just because of the, the chemistry involved in the clinical is. Can you speculate as to whether or not describe the Clover-Bucy syndrome and say that's something we should be looking for in other diseases? Does that help us understand the mechanisms of what's going on?
Well, Clover-Bucy syndrome is a syndrome that was first. This is bothering me. I'm going to take it off.
Under the speakers, yeah. Just get away from the speakers.
Okay.
I'm guessing.
So Clover-Bucy syndrome is a syndrome that is due to the it was originally seen in removal of the amygdala in rhesus monkeys. And there's a whole syndrome of hyperorality, hypersexuality, pacing, poor social interactions, all kinds of things that when we first looked at our MPS 3 kids, we said, boy, they look like this. And Mike Potegal, who worked with us, said, yeah, they really do. All but the sexual aspect of it, and these are all very young children, so maybe not appropriate there to utilize that symptom. But the other symptoms were all like Clover-Bucy. So we devised this risk room, which is a sort of a lab setting where we scared, we had frightening things in the room. We had positive things in the room. We had a startle and a stranger in the room. And we were looking for some of the attributes that we know to be associated with amygdala abnormality, which is lack of startle response, loss of fear, and this is exactly what we saw in these patients with Sanfilippo syndrome. They all exhibited a Clover-Bucy-like syndrome. And then looking at their amygdala, because that's where the Clover-Bucy syndrome came from, we found a big decrease over time in the amygdala related to the lack of fear. So this is very important in MPS 3. Our control group was MPS 1. Okay, so we brought these MPS 1 kids, and they were frightened to death of the room. The other kids, the MPS 3 kids, ran around all the time. But the MPS 1 kids would stand by their mother, because the mothers were in the room. They would stand by their mother. They wouldn't move. They startled. They showed a lot of fear. So it was a very nice contrast between the two. So that differentiates them. And I don't know of any other syndrome that specifically has Clover-Bucy. There's some forms of encephalitis that have been described as having Clover-Bucy-like symptoms. But what is interesting in comparing the MPS 1 and the MPS 3 patients is this same curve of development and plateauing and decline over time, which may be due to the heparan sulfate that both of them have. So it may be that. But that's something that requires more research. Yeah?
Elsa, have you had a chance to look if there's any differences between boys and girls?
We have looked at that. We have looked at it. In terms of the MPS 3 patients, no, there wasn't any difference. And MPS 1 also. What's really interesting to us is in doing this whole study, we realized we needed normal controls. So we have been doing imaging and neuropsych testing in 4 to 7-year-olds, and we've been able to get 4-year-olds into the scanner and stay there for a half an hour, give them a video, and it's better than sedation. And so, so we gathered all this data on 35 4 to 7-year-olds, and we have really nice data from them. And we were looking at, and it came out with there's no relationship between the neuropsych and the imaging. And all of a sudden, I looked at the data, and we looked at it, and I said, let's look at gender. And as soon as you divide the normal controls by gender, we saw huge relationships that canceled each other out because the girls showed a different pattern of imaging, neuropsych association than the boys. And I actually, our two people here are here who did that study, and they can maybe talk to it better than I can. But, it was pretty amazing to see the differences in the growth trajectories in normal girls and in normal boys. I think the thing is about MPS 1 and 3 is that the disease process has such a large effect that you certainly cancel out everything that is probably gender-based in those patients. Anything else?